So that's sort of the hopes of guidelines moving forward, is how do we reach those providers who know nothing about inborn errors of metabolism. So to review inborn errors of metabolism, I know we've had several people sort of discuss the different aspects of inborn errors of metabolism, so we'll go through these slides fairly quickly. But Dr. Vockley was talking about yesterday, here's a central dogma of DNA and how we sort of learn and understand genetic conditions. So DNA becomes RNA, becomes protein. That protein can either become an enzyme, become a transporter, different activities within the body. A lot of treatments are how do we manipulate or go around that protein? How do we give back that protein? We heard yesterday about some novel treatments of how do we even give mRNA back? How do we give that gene back? Different ways to treat. But there's sort of that aspect of as these new technologies and these new medications, these new ways to treat become available, who gets these treatments? How do you give these treatments? Which one is preferred over the other one? And these are questions that hopefully we can develop clinical practice guidelines in the future. So if we zoom out into the inborn errors of metabolism, this matches Dr. Arnold's sort of map from yesterday. And I agree that metabolism isn't scary at all. This is the CTA map of Chicago to me. You see down here is beta oxidation. So here, that means that you guys are South Side. So while unfortunately you have the White Sox, you also get the Pope. So that's been helpful. But I had a great teacher when I was in training that sort of took all of this and simplified it down. It was Dr. Scott Coe at Mass General Hospital. He hated inborn errors of metabolism, so he wanted to create something that was simplified. He's like, how do I teach providers, other medical providers, other medical team members about inborn errors of metabolism without overwhelming them with a large pathway, but still showing that they all connect and they all matter to one another. I think that's really important as we sort of talk about new treatments, new even current treatments of long-chain fatty acid disorders, is everything is connected for the mitochondria. As my teenagers remind me, the powerhouse of the cell works and interacts with one another, is that we have to think about all of metabolism going together, but also helps us move forward in these developments. But when we zoom in just the fatty acid disorders, as a biochemist, we love a pathway. We love to put a pathway in our notes, I think that again, terrifies certain providers. That makes them take a step back. But again, how do we make it simplified and sort of recognize what they need to know? Like in guidelines management of the day-to-day of this condition, I don't need your pediatrician, your physical therapist to be able to draw out the pathway. I want them to know, okay, what are the signs and symptoms to look for, and what should we be doing with those different signs and symptoms? What should we be following, monitoring? Because everyone here who's privileged to see a metabolic physician, some of them are very lucky and get to go see Dr. Vockley. Some of you are less fortunate, have to be stuck in Chicago. But there's even those that don't have any access to a metabolic provider, right? You're working with a primary care physician who's piecing together how to take care of these conditions. But it goes beyond that. So excuse me, with disorders of fatty oxidation, even coming to diagnosis, we know we're fortunate in the US to have newborn screening for many of these disorders, but not every state screens for all 6 disorders. There are states out there that do not include some of the carnitine disorders on their newborn screening panel. So not everyone is getting the same access and the same diagnosis in the newborn period. And then that same access is lifelong. Who's getting the diagnosis management sort of aspect as an adult? How are we diagnosing adults? How are we telling the hospitalists, the interns, everybody that is coming across these individuals, how to recognize and diagnose these conditions? But also, how do we diagnose conditions? It's been very interesting, even through sort of my training program, is the expansion of genetic technologies and the cost of genetic technologies going lower and lower. It's that aspect of, okay, how can we send a diagnostic test to find these individuals and bring them to medical attention so they can get the management that they need? But we need experts to tell how that should be done appropriately. Because if someone's sending off just a carnitine panel and not understanding, it's not documented anywhere that it needs to specifically be acylcarnitines, or if they're sending a genetic panel and they send one gene for VLCAD, but we've missed the 5 other disorders, we're going to miss patients with those conditions. So how do we have it written in a guideline for any provider, any medical specialist that's coming across this individual to say, okay, this is the steps I take to get to that diagnosis? And then treatment is a big aspect. Again, many of us are lucky to work with great metabolic dietitians, different specialists that can help with the treatment, different access to MCT oil or Dojolvi, but not everybody has the same access or the same understanding of what treatment is for these disorders. But even those in a great center, there's disagreement between specialists on what treatment should look like. I think that there's been a couple of times where there's been questions asked by the teenagers, or even those questions alluded to in various people in the crowd of, how come this person's on this amount of fat? How come this person's on this treatment? And honestly, I wish there was a great science behind it. Sometimes it's just what physician you're seeing, at how much restriction you have, what your dietitian has different changes. So if we had specific guidelines, let's have some evidence and some expert opinion behind what patients should be on for their various treatments based on their diagnosis and severity of diagnosis. As we'll talk about later, we have some historical aspect for this for VLCAD, but the other disorders, there hasn't been much in the literature to show, okay, with this specific condition, how do we move forward with the specific dietary recommendations? That's why a lot of it too is we take our best guess and tweak it over the years, but even over time, we're learning that from sort of the understanding is what you need as an infant is very different as what you need as an adult. So let's put that together in a way that people can see and reference. And not everything is just diet for management. I don't want to put a picture of an actual patient up here, so don't tell Hasbro I'm committing some sort of law breaking by using their photos, but I put the bar over the eyes so you can't tell who it is. But I recently had a patient call it all of their ologists, their nephrologist, their cardiologist. I was like, oh, I like that actually, all of your ologists. But all of your ologists need to manage other things, right? They're not managing your diet. They're not managing how much Dojolvi or MCT you're getting, but they are managing what cardiac medications are you on? What are your nephrology medications? What medications or therapies are we doing for your peripheral neuropathy? What is your OT, PT, speech therapist doing? I did notice we have one of each in the room, so it's nice. We should have a little clinic next time with all of them. So all of these aspects, but again, are each of these specialists sort of just making their best guess as what they've seen before? Heart failure for one condition isn't exactly the same as heart failure for another condition. So what is specific for long-chain fatty acid disorders or any fatty acid disorder that we need to be providing proper guidance to these providers? And even something as emergency management. I think of this as sort of the bread and butter of metabolism, right? Is how is someone acutely decompensating, someone who's acutely sick, going through a crisis, how do we stop it emergently and change this? This is all center dependent. It's a lot of, in metabolic medicine, a lot of apprenticeship. What did your teacher teach you to do in terms of what should be on the emergency letter, how many fluids, how fast you should put on? We all teach each other the same things, but even this bread and butter aspects of metabolism isn't well published for someone to access who's in the middle of, I don't know, I'm going to pick on Grinnell, Iowa, because that's where I'm from, a physician in Grinnell, Iowa, to be able to access unless you're carrying that physical letter. I did pick the Dear John sort of style letter though, because I do think that also we have the aspect of, while we're making these management guidelines, we're saying how to treat and manage someone with a fatty acid disorder. What things did we used to do that we still are doing that may change in the future? I'm sure that when I have grandchildren, they're like, what do you mean you have a letter? Why don't you just scan the QR code on your wrist all the time? Well, I think that that's not far from now, that we need to be leaning in technology. And how do we access sort of urgent sort of management, emergency management, that doesn't rely on a specialist being right there in the room? And there's some of that being done already at different sort of metabolic services across the country, that's access to ERs sort of nationwide, or even that access to emergency letters that aren't center specific, but also just something broad, that metabolic sort of geneticists are coming together to say, okay, what's important to include in this letter and why? The nice part about that collaboration, I do feel like as this group is very collaborative, the same thing is happening in genetics, metabolism, we're all very collaborative, but that aspect is there's still those things that need to be put into writing for insurance companies, for hospitals to really put into policy. So how do we get to publications? And all levels of publication sort of matter. So first, there are case reports. Case reports are those where the medical team is sort of putting together an interesting case and lessons learned from that case to put out there. There's actually a lot of case reports in genetics that are all equally helpful, because as we know that there's these rare disorders, these rare presentations out there, it's important to say, okay, this is what may be common knowledge for the disorder, but here's a new fact that we found about the patients, or this is a new finding, or this is a weird way that this patient presented that's different from the norm, or here's a bunch of cases that do present the normal way, but it still took a long time to get them to that diagnosis. How do we put that all together to sort of help sort of build up the medical literature, so people reading the medical literature and referencing the medical literature know this and learn from it? Review articles are another way, research articles are another way. Is that's not just taking like one individual patient, what happened there, but the research that we've talked about over time is, okay, how do we design a study and then learn from that study the science behind the disease, the mechanisms behind the disease, or a new way to treat the disease. So research studies are specifically with a research question in mind and then answering that research question. And then review articles is really just going through and putting a summary together of everything. There's specifically a website that a lot of geneticists use called Gene Reviews that's an active sort of open way to summarize everything that's out there. But still, review articles happen where you go through and review all of the published literature to sort of summarize it for somebody for a quick read of, okay, I need to know everything about long chain fatty acid disorders. Is there a quick review that I can go grab and thumb through for this patient that we're managing in the ICU on the floor, or someone getting surgery next week? The problem with review articles, while it summarizes everything together, it does not give certain recommendations and does not summarize the evidence and review the evidence that we'll talk about that happens with guidelines. If you notice, there's a lot of people in the crowd on these publications. It's because many people sort of are the same people publishing in a small sort of group. It's also because I'm due for promotion and wanted to make sure everyone else knew that. But let's do a short video on guidelines and then we'll break down what guidelines are.
Clinical practice guidelines serve as infallible tools within the realm of healthcare, offering a structured framework to enhance healthcare professionals' decision-making processes. These guidelines are systematically developed to document and synthesize the latest evidence. Clinical practice guidelines provide evidence-based recommendations that guide healthcare practitioners in delivering optimal patient care. At their core, clinical practice guidelines represents a collaborative effort within the healthcare community to establish standardized approaches to diagnosis, treatment, and management of various medical conditions. This meticulous clinical practice guideline and systematic review development ensure that healthcare providers have access to the most up-to-date, evidence-backed strategies. Clinical practice guidelines exhibit distinct characteristics that collectively contribute to their effectiveness. Understanding these key attributes is essential for healthcare practitioners seeking to implement evidence-based practices and deliver optimal patient care. Evidence-based foundation. At the heart of every robust clinical practice guideline lies a foundation rooted in evidence form, the basis of guidelines, ensuring that recommendations are grounded in the most current and reliable research. Patient-centered approach. CPGs prioritize patient well-being by tailoring recommendations to individual needs and specific clinical circumstances. These guidelines consider the unique characteristics of patients, acknowledging the importance of personalized care. Comprehensive scope. To address the diverse needs of healthcare practitioners, clinical practice guidelines encompass a wide range of health-related topics. CPGs provide comprehensive guidance across various healthcare domains. Collaborative development. The development of clinical practice guidelines involves collaboration among experts from multidisciplinary backgrounds. Leading professional organizations, healthcare specialists, and researchers contribute their expertise to ensure a well-informed perspective. Regular reviews and updates. Recognizing the dynamic nature of medical knowledge, clinical practice guidelines undergo regular review and updates. This iterative process allows for incorporating emerging evidence and advancements in healthcare, ensuring that the guidelines remain relevant and reflect the latest scientific understanding. Here are the places you can find clinical guidelines: medical societies and professional organizations, government health agencies, online databases and repositories, peer-reviewed journals, and hospital and healthcare system websites. To learn more about clinical practice guidelines, go to our Care Picture website or click on the link in the description. We have a range of guides and articles to help you learn more about different.
So that was basically a very quick way for this person with a nice, pleasant Australian voice to go over kind of what I've said and what we're coming on the next slides. And it's going to be on the slides that we're saying in case you want to review, but just a quick way to be like, okay, I know that we're talking about all these different research types. There are quick videos out there that sort of help with understanding and care. Oh my gosh. So the key part here is, so first we need to get together a group of individuals. It's not one person writing guidelines. It's a group of individuals coming together from a very diverse background. So we need experts on that condition for long-chain fatty acid disorders. We were working with sort of physicians, dietitians, genetic counselors, physical therapists, occupational therapists, speech therapists are important, but really important is also the patient voice. I met Alex and Stephanie both through this sort of process, is how important when you're making guidelines is something that's going to be clinically impactful and understandable from both the physicians, the medical groups, but also the families to understand and use moving forward. So you have to bring all of these individuals together that consider the experts and review the literature to make guidelines. So we go different places to find the literature, a big pull from online databases, but also this weird place that TikTok told me about. It's called a library. Apparently there you can pull old books and articles there. But it's also the part that's hard is pulling all these articles and everything together. While it's very time consuming, it's also shocking to all of us involved at how much we do, that there's not much literature out there published on why we do what we do. And I think in the future with these two, how much is technology also going to pull things together? I think right now I can't trust what ChatGPT pulls together. So I say, give me all of the articles about this specific sort of writings on LCHAD. Unfortunately, AI has a little bit, if there's a gap there, they'll make something up. And then you get sort of these phantom articles that don't exist. I'm like, that sounds like a really good article. Too bad it's not written. But I think as we improve technology, it's going to be really interesting at how much we can pull together very quickly from supercomputers to then have a review or summary of all of these articles for the medical experts to review and make the guidelines. So once all of this has been pulled together, all this literature reviewed, it's sort of then broken down in specific questions. So specific questions have to be asked while you look through the literature. It's like, how is a fatty acid disorder diagnosed? What diet should be given for fatty acid disorders? You review the evidence, and there's different scores of guidelines. What I think is very interesting is it's the lower the number is the higher the evidence, and then the higher the number is, which is just expert opinions, is actually low evidence, which makes sense, right? Because if you gather toothpaste experts, they can never seem to agree on what the best toothpaste is, but that's going to be true for every condition. Everything that you're putting together is, there's going to be differences on how people manage or treat specific conditions. So an expert may be very different And the best sort of data is those randomized controlled trials that unfortunately in rare disease we have very little of. And how do we push up our evidence, get more publications for these guidelines up? And then they summarize all of these sort of guidelines, the evidence behind it, and make a recommendation based on their review of evidence, their discussion as experts. So currently, a lot of us use the nutritional guidelines for VOCAD deficiency. So this is a published article in 2020. It is a great sort of guidance article that I use over and over again. The problem is it's actually being used out of context for many individuals, right? We're using this across the board, sometimes in clinic for all fatty acid disorders, because there's nothing that exists for the other specific conditions. So if we're using something out of context, the evidence sort of goes down, but we don't have anything else in place. Hopefully soon we'll have guidelines for the other fatty acid disorders, but we're gonna kind of go through how they made the VOCAD nutritional guidelines. And so they sort of have a really nice diagram about what specialists were involved. It was 10 dietitians, 7 physicians that reviewed the literature, sort of broke down what literature they reviewed, how they got to those different articles and that different evidence, and boiled it all down to specific guidelines and recommendations that we use. And they really sort of scored it too, is what was the strength of the evidence, what was the literature out there. And it was really interesting that a lot of it was fair, weak consensus, but it still had guidelines that came out of it. This is, even though there's not a lot of evidence out there, we have a lot of experience as experts to say this, but hopefully we can go back as more publications. The guidelines are not a one and done thing. We're gonna keep going back and keep updating them. And the big thing that came from these guidelines that I reference every day is fasting sort of guidelines for individuals. But again, these are for VOCAD. What is the fasting that we should really be doing for someone with LCHAD, with someone with CPT2? Is it the same? Is it different? And there's not much literature out there to sort of move forward with that at this time. So the next part is interaction. Nutrition, puberty. Patient's perspective is good. Good. So I think I'm seeing some themes here. Again, we kind of, the fasting intervals would be nice to know, is it the same for all different disorders? But there's other things out there that even if we have guidelines for another condition that we're kind of using and borrowing for other conditions, there's other things that we don't have great guidelines on yet on how to manage, take care of. Pregnancy is huge, that aspect. There's very few people out there who are specialists in both OBGYN or maternal fetal medicine and genetics. There's a lot out there that is being asked, and I definitely know very little about pregnancy. Have never done it, have never sort of been through that I am providing what I think as a metabolic specialist should be done, but without that knowledge of OBGYN medicine, that would be great moving forward. Sports also, I think there is this aspect of, are we holding certain groups or populations back from activity in sports that they want to participate in for out of fear and concern for, appropriate fear and concern for catabolism, but how do we improve that moving forward? Yeah, I think all of these are great. Again, the patient perspective is something that has realized. Ethicists are also another group of individuals that are really important to have for future guidelines, because that aspect of, is everyone's voice heard, and is everyone's voice heard equally. I do believe that there are international guidelines in work for publication. I'm going to still keep pushing for guidelines that are US specific too, because there are certain things that come through for just having our healthcare system, our insurance system, our sort of the medications that are prescribable in the US that may not be accessible to the whole world, that may be withheld from future guidelines. So with that, I have no guidelines to share, but want to take any questions or comments that people have about guidelines development or future guidelines, or any question about any of my rambling that would be helpful. I'm also willing to take compliments at this time.
I didn't know how much of a comedian you were, and it was perfect that we put you after lunch because nobody was going to be able to sleep through all of that laughter.
Oh, yeah. Oh, man, I totally missed something.
Oh man, I was just getting ready to compliment you. I'm sorry, I pull it back.
Yeah,
Taylor
Dr. Lee, I'm not taking
Swift.
criticism at this time.
Just to comment on the guidelines that are in progress, which are the informed international guidelines. They were interrupted, unfortunately, by something called COVID, which put them on hold for almost 2 years. So even though they've been in the process for almost 5 years, the last couple have been really the most productive in that. So they will be reviewed at the coming Inform meeting in Japan, and hopefully, I don't know if we get them published as quickly as the end of the year, because that takes a lot more work, but certainly by the beginning of next. And they're very broad-based. We had a lot of European participation, and I think you are right. We need U.S.-specific ones, because there's some things in there that I had to swallow and accept that I wouldn't put if I were to be able to browbeat my fellow American physicians into doing so. But they will be coming, and they'll be helpful, both in terms of allowing people to allowing other physicians to be able to have something to go back and refer to, but also for getting insurance coverage, which is something, of course, that the European countries were not all that interested in. It also included folks from Australia and South America, so it is a world, a real world guideline. So you're right. We will need some U.S. specific, and maybe we could just riff off of those and save a lot of effort. But it would be nice to have something that's specific to us.
I'm not sure if my question will be related to what you said, but it is the question in my head regarding breastfeeding the babies. We all know that breast milk contains a lot of fat, but that has a lot of benefits for the babies, and it will, support their immunities. Is there any guidelines regarding breastfeeding babies with fatty acid oxidation disorders?
Yeah, it's something that's covered somewhat in these guidelines, but again, even though 5 years doesn't seem that long ago, we learn a lot every year, and I think that's something that should be constantly reviewed and sort of evidence-based too, and not just, okay, what are the experts saying? What is the actual sort of scientific proof that one versus the other is the more beneficial for these individuals? And I do think that there's a lot in sort of breast milk that's important, and that we have new technologies to include more breast milk. I think Dr. Kritzer published a paper that talked about skimmed breast milk and using that in a specific baby. So as the technologies change, it sounds sort of burdensome and sort of hard to do. It's not traditional breastfeeding, but if that's an important aspect, how do we sort of set up guidance for that if someone wants to use breast milk rather than a formula?
So kind of going along those lines, thinking outside of the box, so how when the guidelines come into play, as a parent, what do you do, or how do you suggest you navigate, like when maybe your kids are kind of outside of the guidelines, right? Because like the guidelines are amazing and are important, right? Because they give better guidance, but there's always that one, or there's always that 5. And because we're rare, we already kind of recognize we could be the 0.1%.
Yeah. I do think that that's one nice thing that most medical providers understand is not everyone's going to fit into the guidelines, every aspect of the guideline. But the nice thing is still, even if you or your child or loved one don't fit completely in the guidelines, that's still a basis to provide better education, better background for every medical provider touching a different way. Is that, okay, we don't need to follow these guidelines per se, but at least I know what the backbone of how we treat and what we treat.
So I actually had the opportunity to sit in on that FAOD guideline discussion with Dr. Gillian and Dr. Buckley, a lot of others. And I imagine that we'd sit around the table and they would just all quickly agree. And it was not that. It was really fascinating to see.
Yeah.
And I think knowing that the leaders in the field, right, still have different ideas and understanding of how to do this stuff in real time. At what point, as a parent, if you have a question or want to maybe explore different options and maybe your provider is leading you down, at what point should you say, hey, I maybe should get a second opinion, or push back a little, just knowing that what your doctor is saying, a doctor 2 states over might feel differently about.
Yeah, I think it's always great to see a second opinion, but I also like when patients come and say, hey, I've heard this, can you explain why you don't do it this way? Why do you do it differently? Because there's different practice techniques, and I'm very interested in sort of discussing those, why I do it one way or not another. And also I know that my practice style is not going to work with every family, that maybe different providers, or more realistically is what happens is I have patients that see me in Chicago and they go to Pittsburgh to see Dr. Buckley every 1 to 2 years, and that's just, we just share custody and they go from one house to another, and that's actually the best of both worlds, is right, they get to see, I get to learn sort of that shared model. I do think that though it should be a red flag if your provider doesn't want to have any discussion about anything. That doesn't seem like anyone that I know that practices in metabolism, and sort of bringing that up and advocating sort of to have those discussions is really important. Don't be afraid to have those discussions about why we're doing certain ways, because we actually turn into a nerd and we love to be like, oh, I do it this way because of this, and this. So.
Do the guidelines play a role in looking at kind of future research that needs to be done? Like if you see a point of friction, I'm thinking in particular about carnitine supplementation and how this is controversial. I don't like controversy, right? Like, can you just tell me
Yeah.
what we should do here? But is that another kind of role of the guidelines, is to really say these are the points of friction and we really do need to figure these questions out?
Yeah, absolutely. That's one thing that's really sort of nice is that's one thing that we discuss is sort of carnitine supplementation, because there's going to be, if there's no literature out there, there's going to be differing opinions from experts, and then so it may be a statement or a limitation of the guidelines to say we need future evidence for that, and hopefully spark either sort of interest but also funding from somebody to spin off and do that research. There's something similar that came up with our guidelines that we talked about, is how do we manage SCAD differently in every organization, and sort of that aspect too is there's these conversations that happen that trigger new research articles and new ideas to, okay, how do we look at that so next guidelines we can have an updated and informed sort of recommendation. Great question.
I just wanted to echo something that Dr. Buckley said that kind of got lost, is that guidelines are used to set policy.
Yeah.
And this is like, I think we're all here because we are advocates, but I think we need to advocate, like, especially in like kind of a lot of things changing with Medicaid and how things are covered, we need more advocacy at kind of local and national government levels, and guidelines are how we do it. Policymakers, your insurance company, your government officials, they look at guidelines when they are deciding what to cover. And so the fact that we
Yeah, thank you, Dr. Gold, for that point. That's a really big take-home point for this.
Any last questions? Thank you so much,
Yeah,
Dr.
thank you.
Baker.